The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics.
Hey everybody, Eric back with you. Today, I'm excited to be back in front of the microphone. Haven't been able to record a podcast since August of last year when I did the podcast with Scott Weingard. Took a little bit of a hiatus and really needed a break just from the standpoint of creativity and had a little bit of a health scare. I'll talk about that later on, but excited to be able to bring you a really close friend, brilliant educator and advanced practice paramedic from Kentucky, Kari Young, to the podcast. We're going to share a little bit about a nightmare series case that she had, and excited to have you, Kari.
Thank you. I'm excited to be here. I have to tell you, this is a dream come true. Years ago, and I know we've discussed this privately, but you don't remember it. I met you in Nashville, and I had a colleague that said, that guy right there, that's the guy. And you need to hope and work to be half as good as he is. And if you can accomplish that, then you've made it in the world of EMS. So I've kept you on a pedestal for quite some time. You're sort of my EMS hero. So to get to sit here today with you, discuss my nightmare case, it's an honor. Thank you for what you do. Thank you for your podcast. You've been in my ear. Whether I was on the treadmill or riding a horse or cleaning the house, I've listened to them all. Never got bored. Never lost my attention. And I think I'm a better paramedic because of you. So thank you.
Well, thank you. It's hard hearing those things. Obviously, I think the key thing with presenting information is to be able to be humble and honest. I am so glad that the FlightBridgeED Podcast has been able to reach so many people. I was obviously scared to start the podcast in 2012, and it's hard to believe that we're almost 14 years in, but I really appreciate the nice words.
Of course.
So this case, I was involved with this case a little bit, so we'll definitely talk about that. But this is a really complex case, and I think it's one of those cases, whether you're working on a ground ambulance, 911, you're doing critical care ground transport, or you're flying as a flight nurse or flight paramedic, this case really does cross over to all different really arenas. I mean, even from an ER standpoint, this is a complex case. So I wanted to start off. I'll introduce the case. We're going to really go back and forth, and I want her to focus on what she saw, her thought process, things like that. We'll take little breaks and talk about the physiology, the pathophysiology, and I think that at the end you're going to really see that this is a beneficial case to talk about. So you were called for a 58-year-old female 911 call, tone for nausea, vomiting, general weakness. So very, very standard call that we get from the ground side. How did you find your patient? So talk about, on your way, what you were thinking, and who was your partner? Did you have an EMT partner? Did you have a paramedic partner? How does that change really your thought process, or does it?
I think this case highlights, how I feel about bias. And I think this case highlights how it's very easy to take dispatch information and to set your train of thought in one direction and not keep an open mind. This case, I was just leaving another call. We had transported emergency, coming back into the county when this tone dropped. The call came in for nausea, vomiting, general weakness. The patient needed help up. I was working with a very capable advanced EMT who is in paramedic school. He is brilliant. He's going to go on to do amazing things. So I had a wonderful partner that day in Peyton. We arrived on scene. The address was one of those addresses that kind of sat in the corner of multiple streets. So this house was facing one street, but the address was to another street, so the entrance into the home. So we had a hard time getting in. When we got into the home, it was very much a hoarder situation. There was a small pathway that led from our point of entrance to the back bedroom. where I found the patient. The patient was found supine. Her eyes were closed. There was copious amounts of feces all over the floor from the bathroom to her bed in the kitchen. It was evident immediately this patient was sick.
That immediately, I'll tell you, flying for as long as I did, 22 years, I've worked ground throughout that time and definitely worked PRN. But there's a difference when when I go back to previous 2003, where I was full-time ground and you're running calls every single day and it's what you do, you get used to the stuff like that. I mean, as much as you can, right? You get used to it. And I'll be honest with you. I've been back working ground PRN for a year, and I'm still not used to it again. It's hard to walk in some of these houses like that. You just don't get that on the flight side.
No, you don't. But it's also a privilege. I mean, you're getting to see people in their most vulnerable moments. Nobody ever plans to get sick or to get hurt. And sometimes that occurs when your home is not in a state for company. Mm-hmm. And this woman, even though the state was poor, and it had been for some time, and even though she was very sick, she really hated that I saw her home in the state that it was in, especially with the amount of diarrhea that she had had. And that's an honor and a privilege. It's not always the best situation, but it's not lost on me either.
Well, I think that's important to kind of talk about. I don't want to spend too much time. Again, I'm all about being honest and humble, and I definitely feel like, and we've talked about this, you have a level of empathy that I don't have. I just don't, and I'm not probably proud to say that. I've done this 35 years. I'm probably pretty calloused in some ways. You handle those situations much better than I probably do. It's not that I'm mean to patients or rude to patients. I'm definitely not like that. I just don't enjoy that, and you have a different thought process when it comes to stuff like that I definitely don't have, and so that I think that's another whole topic when we talk about bias. It just makes managing these patients much more difficult. That's the key. It makes our job much more difficult, and it's not anything that they're meaning to do.
It's not as simple as just treating a patient. You have to figure out how you're going to get to your patient, how you're going to get your equipment to your patient, and then how you're going to get the patient from the location back to your truck, initiate transport, and not only keep your patient safe, but keep your crew safe.
Yeah, absolutely. So you found your patient supine in the bed, alert, oriented times 4, actively. Was she having diarrhea at that point?
She was not having diarrhea at that point, but she had been very sick within the last hour. I had to tiptoe through the house not to step in it.
Okay.
And so what she told me to do was to just grab anything that I could find and lay it on the floor to try to cover it and clean it up for us. And that's what I did.
Now, was she vomiting at all?
She wasn't initially. The nausea and vomiting came later. And once it started, it did not stop. The diarrhea stopped, but the nausea and vomiting started. And once the nausea and vomiting started, her level of consciousness started to change as well. The patient presentation was definitely different once the vomiting started than what I found when I walked into her home initially.
Okay. So from an initial standpoint, initial assessment, you determined she was sick?
She was sick. It was obvious that she was sick. I didn't know how sick initially. Skin color was good. She could talk to me in complete sentences. I was thinking we're looking at a gastrointestinal issue. She didn't want to look around much. She kept her eyes closed when she talked to me. So I knew she was sick. I just didn't know how sick yet.
Okay. Did you feel like you had the resources available? And I think that's the difference. We have listeners that are ground paramedics, that are ER nurses or ICU nurses or flight nurses, flight paramedics, right? Much different in how we manage patients in each one of those different areas. Did you have the resources available? Did you request other resources?
I requested another truck, and we've talked about this. This is a rural service. we do an excellent job. And I hear you on the humble, but I also want to shout out to my service. We have medics that have put in the work, that show up day in and day out, and we do an excellent job. But in this situation, just simply because of the condition of the home, the small amount of space that I had to work in, I requested another truck, which meant that instead of 2 people on scene, I had 4 people on scene. And without paging out fire, that's about the extent of our capacity on one scene.
Yeah, and so for the audience, this area has an amazing volunteer fire department, multiple county departments that all are under one umbrella, one chief, but really high functioning, and it's all volunteer. So it's not as easy as toning out a paid department where you're going to get an engine every single time.
Correct. Or, we don't have thousands of employees. So when we have one critical run, that we have multiple trucks show up.
Right.
Because we're running transfers, we're running 911s, and we have a fairly large county.
Right. So that's where I enter the call. Is I'm the second truck that is show up. I'll tell you, I roll up and I see Kari standing outside with gloves.
Chucks.
She has chucks, and I realize that things are not okay.
No, things were not okay. The patient wasn't okay. The conditions in which we were working were not okay. The path to get to the patient was not okay. And we had a very limited amount of space to work.
All right. So from just a really quick overview, past medical history, what did you find out? Give me kind of an overview of like the previous couple days.
So even though she was alert and oriented, she was sick. So getting information from her was difficult. She told me that she was in kidney failure. She told me she was a dialysis patient. She told me that she had been inpatient in a local hospital. She did not tell me that if she was discharged or if she signed out AMA. She told me when her last dialysis treatment was, and ironically, it was within the last 24 hours. So my train of thought shifted. I knew that I had a dialysis patient. I knew that I had a patient who had been seen in the hospital. So I started working with different possible diagnoses.
Okay. So initially, so she had dialysis 1 day prior.
Correct.
Is that correct? All right. So let's just say, I'll bring myself to this, into this. I entered the house with you and my partner, and I think the immediate thing, and this is the side again that you miss on the flight side, is you don't enter these houses. You don't have the bias to the extent. You don't have the elements of there's feces everywhere. You got to deal with the smell. You got to wonder how you're going to walk through the house, how you're going to get through the house. So it's really easy to miss the little things. Mm. Later on, when I was able to step back and look at the case, it was absolutely evident.
Yeah.
And we talked about it on some of the things we're going to talk about. But from a primary assessment standpoint, what was your primary and secondary assessment? So primary assessment, and we'll go secondary assessment.
Primary assessment, I was thinking that I had a gastrointestinal issue. Secondary, once I started talking to her a little bit, I was beginning to wonder if I had an electrolyte imbalance. It didn't take long.
Sure.
So when I entered in the house initially, it was obvious that she was sick. But she was laying in her bed. Skin condition was pink, warm, and dry. Now, granted, there was stuff everywhere. And I may have been a little sidetracked with trying to navigate the amount of diarrhea and feces that I had in the very, very small space that I had to work with. Her radial pulse was regular. It was strong. Her breathing was, 20, 22. She could talk to me. She didn't want to give a lot of history. It was obvious that she was sick. She really wanted to rest. She wanted to keep her eyes shut. She told me that she could not walk out of the house. Okay. And so then I had to start figuring out how I was going to get her out of the house. And that's when you came on scene. So when you came on scene, I was outside getting the stair chair. I knew the stretcher could not. Even if it had been an ideal circumstance, there was just too many turns and twists to get to her for the stretcher to get into the home. a Smith cot was going to be way too taxing on her. I don't like carrying any patient on a Smith cot. There's an amount of dignity I think a patient loses every time we have to do that. And so my partner and I elected to start with the stair chair. We covered it in chucks. We had sheets. And when we went back into the home, she was pale, she was clammy, and the nausea was worse. And that's when the vomiting started.
Okay. So at this point, so when we start talking about nausea, and I remember, she says, now I'm sick to my stomach. She's actively vomiting, which delayed our ability to get her out.
Yes. Because she completely, once she started vomiting, she completely shut down. She didn't want anybody touching her. She didn't want to move. And this woman's nausea and vomiting was so bad that, she just was leaning over. There was no containers to catch it in. She couldn't hold a container. So she was just kind of vomiting and it was landing just wherever it fell.
Yeah. Yeah, that makes it tough. So from that standpoint, I just want to kind of stop. You elaborated a little bit on differential diagnosis, and I think it's always important at that point in any call to kind of get your mind right of what am I dealing with. And you had said earlier, electrolyte imbalance, right? And I think that's great. Anytime you have nausea or vomiting and diarrhea, we have to think about metabolic derangements. We'll talk about that. Electrolyte imbalances. But what are some other differentials that we can kind of clue in on for her? And again, we'll come back to, at the very end, we have her outcomes, so we know what ended up happening. And there was definitely some surprises as the call moved on. But what are some, 3 or 4 differentials that we can kind of consider?
Well, I'm watching her. I see the evidence of the diarrhea. I'm watching her actively vomit uncontrollably. So I knew she was a dialysis patient. She's in kidney failure. So I'm thinking about electrolyte imbalance. Kidney failure leads me to think about UTIs, possible sepsis. The GI was a given. I didn't know the origins, what was causing the GI, but it was definitely a given. And I had a limited history, but also in the back of my mind, I was thinking DKA. She didn't present like a typical DKA patient. Her breathing was regular. She had no mention thus far of any diabetes at all. She just said she was weak. She didn't feel well. And so I'm thinking electrolyte imbalance, sepsis, GI, hypovolemia. I really just wanted to get her out of the environment that she was in to a cleaner space, a bigger space, so that we could start working with her to help her to feel better and see what was going on with her.
Okay. So at this point, we were able to get her out of the house. Actually, it went pretty smooth. I didn't really think it was very difficult to get her out of the house.
No, surprisingly.
We get her into the ambulance, and we'll come back to the differentials as we move on. So let's start from there. We get her in the ambulance, and what do we want to do?
Well, we started with gathering vitals. The patient's a dialysis patient, so she had a shunt in her right arm. She's dehydrated. We have no vascular access whatsoever. I looked, you looked, my advanced EMT partner looked. We did not have vascular access. So while gathering vitals, putting her on a cardiac monitor, we established an EJ with a 20 gauge. And then we started a fluid bolus. That amount of diarrhea, that amount of vomiting, I knew I was dealing with a hypovolemic situation. Her blood pressure was soft. Initial pressure was 109 systolic over 40. Heart rate was 92. SpO2 was 100. Her MAP was 63. Her shock index was 0.8, and her end tidal was 13. And that bothered me.
Yes, let's talk about that. Why did you put end tidal on her?
I put end tidal on her because she's a poor historian, for one. Something in my gut said this isn't right. I knew that I wanted to resuscitate. Even though her SpO2 was 100, she looked like crap, honestly. So I wanted to get some oxygen on her, and I know all the arguments around oxygen, whether it's needed or not needed, and if you should give it or you shouldn't. But this patient was sick. So I decided to use the tools at my disposal. I had an end-tidal nasal cannula. It gave her some comfort, and it gave me a lot of information. So I had an end-tidal of 13. Her respirations, I don't know, Eric, she wasn't tachypnic when I think about tachypnic labored breathing, but she was definitely faster than 20. So I'm gauging her 22 to 25 breaths, depending on if she's talking to me, if she's heaving, or if she's just able to lie still.
Yeah, so let's talk about that. Obviously the sepsis guidelines changed in 2021, and they identified that the number one most sensitive vital sign that we have, and I really push this in any course we teach, is respiratory rate. And I reflect back at myself in EMT or paramedic school, and I think it's really easy to have bias when you see somebody that's tachypnic, right? It's easy to automatically think they're having anxiety or they're hyperventilating. I had a pediatric patient I flew out last night that was hyperventilating, and it's really easy to just clue in and just think it's either hyperventilation, it's anxiety, it's something behavioral. But I think we've learned that is the body's immediate way to compensate. Is the sympathetic response kicks in. We have some type of hypoxemia underlying, right? Even though SpO2 might be fairly normal, doesn't mean that PaO2 is normal. And that's where we get into the whole right and left shift on the hemoglobin curve. And our body is increasing minute ventilation for a reason. The only way it can do that is by taking sometimes deeper breaths like Kussmaul breaths and DKA, but usually by increasing the amount of breaths that we take. And so I think for me, reflecting back at her, I remember you put her on the end-tidal, or you said, hey, should we put her on end-tidal? And I'm like, yeah, that's a great idea. I thought it was amazing. I hadn't even been thinking that, honestly. And then it came in at 13. Right.
And I think at this point, this was a failure on my part to see the big picture. I was very focused on, I recognized the tachypnea. I knew that it was there, but it wasn't so pronounced that I'm like, oh, we got a problem here. It was very, very subtle. And in my mind, I dismissed it to, she's been vomiting. Mm-hmm. She's had diarrhea. We just moved her from her bed that she was supine and couldn't move on her own, put her in a stair chair, strapped her into a stair chair, took her to the ambulance, moved her from the stair chair to the stretcher, put the stretcher in the truck, and now she's surrounded by 4 providers trying to obtain vitals, trying to establish an IV. And like I said earlier, the vasculature was non-existent.
Yeah.
She is very much aware that we are starting an EJ in her neck and trying to coach her through that. So I was able to rationalize the tachypnea to just stress.
Yeah.
Because she didn't present as a patient that was experiencing Kussmaul's, for example.
No, she did not.
You and I both have a good friend that says vital signs are vital. And that was a failure on my part.
One of the areas I want to focus on is we got the EJ established, gave her a fluid bolus. She was actively vomiting. She becomes a little bit more obtunded. And I think the discussion we went back and forth is like, do we give her Zofran because the vomiting was extensive, or do we go Phenergan? And let's talk about really the decision on what we went with.
So my rule of thumb is if a patient tells me that he or she is nauseated, but I don't have active vomiting, I typically go with Zofran. I don't have a problem with that. Once active vomiting begins, I don't need any further proof that this patient does not feel well. I don't like to vomit. I don't want to vomit in front of people. So I will tell you 1,000 times over, give me Phenergan if you see me actively vomiting. So if that's what I want for me, then that's what I try to do for my patients. So I chose to bypass Zofran and I gave her Phenergan.
Okay. All right. So at this point, I think just to recap, vital signs, blood pressure was 109/40, heart rate 92. She had SpO2 100%. That was never really an issue. MAPA 63, shock index of 0.8, and her end-tidal again was 13. So I do want to talk about her end tidal. And, in previous podcasts, and I think it's important that we hit on this. Me being on this call and looking at this patient, I remember reflecting and thinking that did not match the blood pressure, right? And so remember the 3 P's of end tidal CO2. Does she have a pulse? Well, she had a pulse. She wasn't dead. She had a MAP of 63. So that leads us to end tidal is probably low because of that. Probably not 13 though. So that alarmed me a little bit. I'm like, but I don't think I put 2 and 2 together at that point.
I didn't either. And I think at that is the point that I looked at you and said, she's septic.
Yep.
And you and I made eye contact, and we both then referred back to her vitals. And even though her pressure was soft, she didn't really have the typical septic physiology. And we talked about that.
Yeah, interesting. And I also, and guys, I don't always have all the answers, and I think that's something that you elaborated on in the very beginning about, all the podcasts and things that I've done from an education standpoint, and me trying to be, me being humble. I definitely don't have all the answers. I definitely get on these calls, and sometimes they're not as clear as they probably should be. And, we have to be a detective. And I think although I instinctively realized the end tidal was 13, it didn't match because she wasn't actively over being tachypnic. She wasn't at a rate of 36 a minute Kussmaul. She wasn't obviously from my assessment, she wasn't in this partially compensated metabolic acidosis. It was just like, bam, right in your face. But I think it was very interesting at FAST 26, Will Heuser talked about a new concept called the modified shock index.
That's correct. I said it on his pre-con.
Yeah.
I have to tell you, Will Heuser is one of my favorite people in all the world. Even if I did not know him personally, he's so dynamic. He's so smart. He spends the time. His work ethic is beyond compare. But he's incredible. And I didn't even have to know what the pre-con was about for me to be present. I swear he could juggle and I would be present to watch. But he did. He introduced a new shock index configuration.
Yeah, so it's called the modified shock index, and I would agree. Will is a brilliant guy, and I think that really comes back to surrounding yourself with brilliant people. Iron sharpens iron, and there's a lot of amazingly brilliant people out there that if you are surrounded by those individuals, you become better just automatically, right? And it really does. And it's obvious, it's apparent when you meet people like that.
He lights a hunger for sure.
Yes. So going back to this call, I remember her diastolic. And again, reflecting on that, I talk a lot about diastole in our critical care courses in advanced hemodynamics, and that, a lower diastolic number is a reflection of the heart has a lower pressure at rest, and that in most cases, that's what we want. That's a reduction in afterload.
Right. So do you want to explain the modified shock index?
Yeah. And so in this case, that's not a good thing.
No.
It's a bad thing. And so his modified shock index is basically you take the heart rate and you divide it by the diastolic number. And if it's greater than or equal to 2.2, that's significant. So obviously we have a shock index. Normal shock index is anything greater than 0.8. So we always say equal to or greater than 0.9 is a number that we want to shoot for. And you're going to take your patient like that, and you make decisions based on ketamine and medications. But this modified shock index is a new concept.
You and I looked at her, and the shock index prior to Will Heuser was 0.8.
Right.
We were
right
borderline.
Yeah,
we were
right
borderline.
Yeah.
And so, we were kind of skating on thin ice there.
But if you do the modified, she's actually at 2.3.
Yeah.
Right.
Which says she's in trouble.
She's in trouble. And so that's something you could add to your tool bag, guys. When talking to one of my closest friends, Dr. Bonta, I brought this to him, and he kind of laughed at me, and he said, from a medical direction standpoint, he didn't really like it. And not to call him out on the podcast, he's amazing, but he's looking at it from how many paramedics and nurses that he is over from a medical direction standpoint, and he's thinking about the education and delivery, and he's thinking about, we're struggling still in some areas to make sure we're evaluating shock index the normal way. And when I bring to him, hey, we've got a new way of looking at shock index, he about vomited, because he's like, how do we, we're not getting it right in the standard method.
Well, and I'll be honest with you. As you know, I'm from a rural area. Shock index became known to me a year ago. It wasn't a vital that I spent a lot of time looking at. It was never discussed in any of my EMS courses. And so I kind of hear what he's saying. We're just now getting providers aware of shock index. We're just now getting them to look at shock index. We're just now getting them to consider shock index and before they start their treatment. And so we're going to, hey, wait a minute. You've been doing it, but I got another way for you to do it. So I can see the frustration from an education standpoint, especially when the man's credentials are on the line with every single clinician contact with a patient. I can understand his frustration.
What I would say is that maybe it's an added tool. Maybe if you're on the cusp and you're trying to make good clinical decisions, or what I would say is if you see a diastolic number less than 50, and I know that's something that Will talked about, raise the red flags, right? It's about recognition. It's about raising those red flags. And then maybe at that point you do a quick calculation. And again, if you do that, you take their heart rate of 92. She had a heart rate of 92. She had a diastolic of 40. That's a 2.3. And so that is where and we'll talk about this as we get through the podcast, decision-making related to shock index, but she definitely had the clinical signs from her vital signs that she was in trouble.
Yeah. And you and I have spent a lot of time talking about prophylactic treatment with that borderline shock index. So Will Hoyser definitely gave us a new tool for our tool bag so that we don't have to consider that thin ice anymore. We're no longer skating right on the borderline. We can figure the modified shock index and have a definitive answer.
Yeah. And so for those of you that don't know who Will is, he's been on the podcast a few times. He's a PharmD. He's a toxicologist. He's also a flight paramedic. That's actually a PhD, MD candidate right now in medical school. He's a
Mopar man.
Yeah, a Mopar man. So, he is. He definitely has the credentials and backing. Works at Stony Brook in New York City, and pretty amazing guy. So at this point, we've given the Phenergan. She definitely is declining from a mentation standpoint. That started right when we got her in the truck. Had to do something about the vomiting. She just could not. We just couldn't manage her at that point. So let's start talking about really your decision making and really the realization from an airway management standpoint.
So it was at this point, I felt like our scene time was extensive. It was time to get this patient moving. It was obvious this patient was sick. Just extricating her from the home in itself was time consuming. Vasculature was non-existent, soft pressures. We had to do the EJ, then we started a fluid bolus, then we contemplated, and I don't mean to sound like we drug it out. We definitely did not, but there was a lot of discussion amongst 4 providers. Then we started the fluid, we started the Phenergan. It was time to move. And I have to say, in all the busyness, there was a vital that was left out, was not done as soon as I like for it to be done, and I'm sure as soon as you like for it to be done and within your patient care, and that was their CBG. So I initiated transport. Thank you for coming and helping me with the extrication from the home, but it's time to get this patient moving. I initiated transport.
Yep, and I returned to service. I went available.
Yeah. So I initiated transport emergency. You returned to service. Thank you for your help in extricating her and your kindness towards her. But it was time to get her to definitive care. I looked down, I realized that I have the catheter from her EJ, and it occurs to me I didn't get a CBG in the home. I haven't obtained one since moving her to the ambulance, and I have no idea what this lady's CBG is, which is a vital that I like to get really early in my patient care.
Absolutely.
When I was going through all of my education, it was pounded into us. Do not be that provider that flies a stroke patient that just really is hypoglycemic. So I made it a point of practice. I get it early, but I had not ascertained her CBG. And so I did it at that point. We had fluids going. I had medication. I had her on oxygen. I knew that she was obtunded more than what she was at my point of contact. I was monitoring that closely. CBG, it doesn't even read. So then everything made sense. I had an end tidal in the teens. I had a patient with vomiting. I had a patient with diarrhea. I had a patient that was tachypnic, even though it wasn't Kussmaul. She was tachypnic. Mm-hmm. I had a patient that was increasingly more obtunded than she was when I first made point of contact. And I have a patient that I've given Phenergan to control her vomiting. And now I have a patient that can't raise her head up. And I have a patient who cannot control her airway, and her clinical course is poor.
Yeah, so let's talk about a few things. Obviously, I think there's different thought processes. We've talked about this, right? Phenergan in that situation, I agreed that it was probably the best option. But we know Phenergan is going to cause them to in some patients really react pretty strongly to it, and then you're going to, you've said you'll sleep for 24 hours.
Yeah,
right?
You give me Phenergan, and you don't have to worry about me. I mean, I am in bed. Give me my comfy shoes, my comfy jammies, and Phenergan in 24 hours, and I am out.
The other side of the coin is, do we give Zofran and maybe even double the dose, do a cancer dose of 8 milligrams? Is that gonna work? Again, it's a decision at that time, and we opted to go the Phenergan route. Her mentation handled it fine initially, and everything was kind of coming together and colliding together. So, did it make her mentation drop a little bit? Probably. Did it change anything honestly, that we were going to do? No.
I think it was minimal.
Yeah.
I think her clinical course was already set.
Okay. So from that standpoint, obviously, I would agree. I had left the scene. You had started transport. CBG comes back high. You send me a message and say, hey, look at this. I'm like, good catch. Obviously, again, we hadn't checked her sugar. I mean, it was busy. And so at this point, let's talk about airway decision-making.
So I'm evaluating my patient. Know how the patient presented to me at my point of contact. And I know the patient that I'm looking at now. And she's deteriorated. And I think one of the hardest things for any paramedic to do is to make that decision to paralyze, sedate, and intubate. And I think, honestly, if you're a provider who fails to see the weight of that decision and the weight of that action, then it's time for you to take a step back. One of the hardest things for me as a provider is to sedate and paralyze a patient. I mean, you're taking away compensatory mechanisms for that patient. It's scary. It's scary for the patient. It's scary for the family. And I don't do that lightly. But I'm watching this patient who is deteriorated, who can no longer control her airway. Not that she probably could very well to begin with, even though she was alert and oriented, she was sick. And I should have recognized initially that it was only a matter of time before her ability to control her airway decreased significantly. So I made the decision. It was time to make a hard choice. And we had established transport. I told my partner to pull over. We pulled over on the side of the road. I started active oxygenation, and I called for a second truck. And the reason I called for a second truck is just simply because it's good practice. Do I believe in my ability to take an airway? 100%. But Do I want to make sure I've dotted my I's and crossed my T's and I have considered all patient safety before I do that? Absolutely. So I called for that second truck.
Well, and just for context, in this county, we don't have to have 2 critical care paramedics. So critical care, advanced practice paramedics in Kentucky, that's the new designation. So you can have a previous critical care endorsement or hold the FPC or CCP-C from the IBSC. And that's a new standard in Kentucky. And so anybody that has that designation is considered an advanced practice paramedic. Or you can hold the wilderness paramedic or the community paramedic designation from the IBSC. So all of those are recognized as advanced practice paramedics. So from a standpoint of our guideline in Kentucky, there's not very many counties in the state of Kentucky that are approved RSI. You have to be approved by the state of Kentucky. Obviously backed by the medical director, have to have good training in place and a good CQI process in place. So we're one of very few in the state that are allowed RSI. From that standpoint, we've made it a mandatory thing that, if possible, we can have 2 paramedics on scene at any time we RSI. It doesn't have to happen. If there's a pediatric patient, there has to be 2 critical care paramedics on the truck or in the truck at the time of an RSI. And so, again, if resources allow it, and that's why she called for a second truck again for that purpose.
I think it's just good practice. Not only is it mandated, but it's just good practice for a second provider to be there for patient safety. And I would say that in any critical care situation. Okay. So I removed the end-tidal nasal cannula because an end-tidal nasal cannula will only deliver 5 liters per minute. And with passive oxygenation, I needed something much higher. So I removed it, put a nasal cannula on her, set that to 15 liters per minute, put a non-rebreather on her, set that to 15 liters per minute. Started passive oxygenation. And honestly, SpO2 from the point of contact of this patient was high. It was 99 to 100 every single time. Requested an additional truck and then started preparing my meds.
Okay. So let me just stop really fast. I just want to make sure everybody's on the same page. Again, lots of stuff to cover in this type of podcast. But remember, in the critical care environment, we're actually looked at and evaluated from an airway management standpoint regarding -1A. And the -1A was something that was invented and thought of by Dr. Bill Hinckley out of University of Cincinnati Air Care. And -1A stands for definitive airway sans hypoxia, hypotension on first attempt. And so the way it's evaluated, it's not about ET tube passing through the cords. It's about what is the resuscitation mindset before and after intubation. It's not about the ET tube. Obviously, we want first pass success, but what we want first pass success without desaturation and hypotension. And so from an evaluation standpoint on the air medical side nationwide, it's not about you passing the ET tube with the cords on first attempt. It's about what is the blood pressure right before that attempt. Is systolic greater than 90? Is SpO2 greater than 90? Now, companies have raised that bar to 100 systolic to 94% SpO2, but from a -1A standpoint, it's 90 and 90. And usually that's achievable. That's something that we do from a passive oxygenation standpoint. We resuscitate well. We've done a really good job in the education space in that area. But then you intubate and you think you have success.
Yeah.
And you drop your guard. What happens up to 10 minutes after intubation? Let's say you're at 9 minutes, 30 seconds, you check a blood pressure. Now systolic less than 90. You had first pass success, pass the ET tube, no problem. SpO2 is greater than 90%, but systolic is now 85% or 85 millimeters of mercury. It's a failure. It's a failed attempt at that point. So it really comes back to thinking about the patient from a big picture standpoint. Remember, TBI patients, you have one period of hypotension, one period of hypoxia. Each of those hold a 50% mortality rate. So we really are focusing on the resuscitation standpoint. And so from a -1A standpoint, passive oxygenation, resuscitation, push dose pressors, being able to evaluate shock index, evaluate modified shock index, slowing down the airway management and taking our time and evaluating those pieces carefully before we pull the trigger is so important. And I think when I look at that standpoint from an education area, that is what I focus on every single day.
Right. And -1A is what led my thinking when I decided to intubate this patient. So when I made the decision to intubate, I told you I started the passive oxygenation. I had not had a problem thus far with hypoxia, according to my vital signs. But my pressure was soft, and my pressure had been soft from the get-go. And even though it was above 90 systolically, and even above 100, I wasn't comfortable. Her pressure at this point was 109/43. We had a heart rate of 90, SpO2 100, and tidal was 12, and her shock index was 0.8.
Okay.
So I made the decision prophylactically to push 10 mics of push-dose epi because I'm thinking about the 10 minutes or the 20 minutes after I intubate this patient. She's already sick. She doesn't need me to make her sicker. So 10 mics of push-dose epi. How
do you mix that, by the way?
How do I mix it? Well, we take a flush. We expel 1 ml. I take a cardiac dose of 1 to 10,000 epi. I draw out 1 ml. Mm-hmm. I mix it, and 1 ml equals 10 mics.
Right. And so, guys, remember that's now it's 1 in 100,000 from a standpoint of ratio. And you're just given 10 mics at a time.
And I mean, honestly, I probably could have hung norepi at this point. And I know there's some services. Jeff Jarvis is advocating for prophylactic norepinephrine with all of his RSI cases.
Yeah, no matter what.
No matter what. And I could have done that. And probably in hindsight, I would have. Because I had some time. I was waiting on that truck. I was keeping a close eye on her. But I didn't do it. I chose to give the 10 mics. Then I estimated her at 70 kilograms. Even though I had a shock index of 0.8, with the 10 mics, I knew I was going to see advantageous response. And so I gave 1 milligram per kilogram of ketamine, which is 70 milligrams. And I pushed that slowly. I started the timer when I pushed it, and I pushed it over 2 minutes.
Okay. Yeah, so let's talk about that. And you guys, there's been lots of discussion about shock index and about lowering ketamine dose. And, I think the standard across the board is that we give 1 to 2 milligrams per kilo. 2 milligrams per kilo if the standard shock index is normal, right? We're less than 0.9. A lot of programs have gone across the board to 1 milligram per kilo. Really don't need to go 2. And some programs have even dropped that to a 0.5 milligram per kilo if you have a shock index greater than 0.9. Yeah. Now, you talk to some pretty powerful names in the industry, Weingard, Jarvis. You talk about Will Heuser. You talk about the new study that just came out comparing etomidate to our ketamine. They're basically saying it probably doesn't matter. So again, I don't know how I feel about that, honestly. Ultimately our medical director is going to make that decision. I'm probably pretty comfortable with consistently staying at 1 milligram per kilo. And you've heard me say this over and over on different podcasts. I'm a pretty aggressive paramedic. I am not afraid to pull the trigger on things. But I also know from a medication standpoint, you can give more if you need it. You can't take it back.
Right.
So it's always better to be conservative. So, again, her pressure was soft from a diastole standpoint. Honestly, we had not heard the talk by Will Heuser at this point at FAST, so we hadn't really talked about the whole aspect of modified shock index. I hadn't really brought up the whole aspect. I mean, I noticed her blood pressure, her diastolic pressure being low, and I think I even talked about that next morning. So I don't have a problem with you going with 1 milligram per kilo. And our guidelines there at Allen County, we have a shock index greater than or equal to 0.9, we lower the dose of ketamine to 0.5.
Yes.
Right. And if you want to refer back to, we did a podcast with Dr. Stevenson, Dr. Jarvis, and Dr. Loria. I was not involved in that podcast where they talked about these shock index patients, high shock index patients, and should we even give a sedation medication, induction medication? Should we go paralytic only? And I wanted no part of that podcast. Let the physicians talk about that, medical direction talk about that, right? And you had an anesthesiologist out of San Antonio area that really advocated for no sedation.
I'm just going to say this. This is just two friends talking publicly. If you have to RSI me, sedate me.
Yeah.
Please.
And I think Jarvis and Loria really thought that was probably the better option. Dr. Stevenson looked at it from a data standpoint and said, listen, if their GCS is 3, they're not going to remember. It's about saving their life. And have I as a flight paramedic ever given a patient from a crash airway standpoint just a paralytic and no sedation? Yeah, probably a handful of times, maybe a dozen times or a half dozen times. But it's been a life or death situation where I felt like from a hypoxia, hypotension standpoint, I had to do that. Does it change the outcome? I think all those patients died, right? They're so sick. So I don't know.
I hope we never know.
Yeah, you don't know. But I have talked to flight nurses, flight paramedics, honestly, in our courses on where they have been sick in the ICU, and they have been on the vent, and they've been undersedated, and they remember it.
Well, there's a I don't know. Can I throw names out here? Mm-hmm. So the pre-hospitalist, I follow her on Facebook, on Instagram, and I can't remember how long ago it was, but she did a post about patients who were supposed to be sedated and paralyzed and what they could remember. Patients who even CPR was in progress and what they could remember. And it was eye-opening. And I'm so sorry to the pre-hospitalists. I wish I was doing a better job in surmising or giving a synopsis of your post. But it stuck with me. I think about it with every single patient. And it was, your voice was in the back of my head with this patient. And we'll talk about that a little bit more when we discuss my ketamine administration and how much ketamine I gave. And it was because of the patient's signs and symptoms and sedation and what I thought was necessary.
All right. At this point, you have started passive oxidation, blood pressure and vitals right before intubation, BP of 109/43, heart rate at 90, SpO2 100%, end tidal CO2 of 12 at this point. Shock index is unchanged at 0.8. And so let's start talking about the pharmacology. I know we talked already about your decision to make or deliver a push dose pressor at 10 mics. And after the 10 mics, your blood pressure comes up to 129/53, heart rate of 102. So let's go through ketamine, rocuronium, and really that thought process.
So I decided to sedate my patient with 70 milligrams of ketamine at 1 milligram per kilogram because I did have an improved pressure of 129/53, heart rate 102. I knew my shock index had improved. So I started my timer, pushed my ketamine over 2 minutes, and surprisingly, with the fluid resuscitation, the oxygen resuscitation, the phenergan on board, it took 3 minutes, additional 3 minutes for my ketamine to sedate my patient. And then I followed with 70 milligrams, 1 milligram per kilogram of rocuronium.
Yeah, I think that's an important piece, and we had talked about this prior to this case, just from an RSI education standpoint of, a lot of great medical directors that have good data, and Jeff Jarvis really talked about how important it is to wait the 90 seconds after ketamine before you even push the rock, and then wait another 90 seconds after the rock before you try intubation, that we have to make sure the medication has time to take effect, that our first pass success is really dependent on those elements. So we really focus on that in the education space. but it took longer for her to go down. And I think looking back afterwards, right, she had polypharmacy. She definitely had
Correct.
a lot of medications that she'd been using over the years. And so it definitely, I think it was a beneficial piece to make sure that we were doing that the right way. Again, I wasn't on scene at this point. I was the second truck that you asked to come back to the scene. So I was responding. You were at the county line. And
Per protocol.
Yeah, per protocol. Yep. And so at this point, you recognized, hey, it's taken a while. You kept making sure that passive oxygenation was happening. SpO2s were normal. 3 minutes came and went, and you noticed at that point that she had now been well sedated, and you opted to then go to rocuronium.
Correct.
All right. So talk me through the intubation phase again, from a standpoint of just overview. I was not on scene yet. You were the medic on the truck by yourself, and you continued with the procedure.
I did. I was taught very early with any RSI procedure to get a timer started, a visible timer. EMS seconds and actual seconds are two different things. So I had started my timer. When I introduced the rock, I was 3 minutes in. I waited 90 seconds, thank you, before I inserted my video laryngoscope. We use a video laryngoscope with every RSI. I use a USB bougie. I'm a firm believer. I like the USB bougie. It allows me to maneuver without such rigidity in the airway. Inserted the USG bougie, saw clear passage of the bougie between the cords. I never, Dr. Bonta, preload my ET tube on my bougie. Used a 7.0 ET tube. Watched it pass through the cords, set it at 21 centimeters at the teeth. I had immediate waveform capnography verification at 18. We had equal and adequate rise and fall, clear breath sounds, inflated the bulb, secured the tube, and as I was securing the tube is when I think you arrived in the truck.
Correct. All right, so let's talk about that. So USB bougie, if you're not available or are not aware, is a bougie developed and invented by Rich Levitan. It's sold by Intersurgical. It definitely is a game changer, much better than the standard blue rigid bougies that we've been using for years. So it definitely is a game changer. And if you have or want any information, please email me at eric.bauer@FlightBridgeED.com.
And can I just say this?
Yeah.
If you have failure using the video laryngoscope and the USB bougie on a live patient, it's failure to practice.
Absolutely.
The video laryngoscope is a game changer. You have to operate it differently than a direct, and give yourself a little bit more room.
What's the number one failure?
Being too deep.
Yeah.
Getting too deep. You take away your ability to move around inside the airway. You may pass the bougie, but then you won't pass the tube, or vice versa. Or you may not pass the bougie at all. So if you find yourself frustrated with video laryngoscope and a USB bougie, or a bougie in general, then get back into your training mode. Pull your laryngoscope back and try again.
A little goes a long way, and I think that's the whole aspect of changing that. And I think we've come a long way with DL versus VL and the technology, and a lot of programs have found the same thing. And I can reflect and say that was my failure point, just practicing when I was going too deep, because that's the way we were trained. And so now we just try to train to go down the midline a little at a time, lift a little at a time, until you see a Cormac-Liane view 2. That's what we're looking for, not a perfect view 1.
Which contraindicates everything that the textbook says.
And paramedic schools are teaching that. A lot of them. Maybe not the most progressive ones, but a lot of paramedic schools are still teaching the old way.
Yeah.
Yeah. All right. So you have end-tidal CO2 of 18. You have a good waveform. Obviously, that's definitive. And I think from a standpoint of, if you decided if you were in a helicopter and you intubated in the helicopter, remember, you can't listen to lung sounds. So from my standpoint, having worked aeromedical for 22 years, I could care less about lung sounds, right? I know from a ground side, from a confirmation standpoint, from a charting standpoint, we want 5 points of confirmation. But ultimately, guys, end-tidal CO2 waveform capnography is the definitive way to confirm ET2 placement. All right, so let's evaluate vital signs after. What were you at currently?
So I secure my tube and we immediately evaluate vital signs, and I have a blood pressure of 104/42. Remember when I introduced the idea of RSI, I was at a pressure of 109/43. So I have had a decrease in blood pressure to 104/42, heart rate 95, SpO2 is 100%. I have an end-tidal of 18. MAP is at 63. Shock index is 0.9, and my modified shock index is 2.26. So,
yeah. So, not a huge change. Obviously, MAP is still 63, so that's the same. Diastole is still low at 42. Your systolic has dropped a little bit. Shock index, though, is now greater than what it was before. You started with push dose pressor. You gave epi prior. You have modified shock index now is a little bit higher. And again, that's retrospective, right? We've added that to this case after the fact because that's something we learned at Fast 26.
correct.
So, what do we do now? Are there any concerns about, obviously you have to ventilate this patient after intubation, and then do we continue with push dose pressors?
I'll tell you what we didn't do. We didn't high five in the ambulance and consider it a successful intubation. We immediately pushed another 10 mics of push dose pressor and reevaluated our vital signs.
Okay, what would you have?
After the additional 10 mics, my vitals were 150/52. Our heart rate was 104. SpO2 was 100. End-tidal was 20, which was the best that we had seen. MAP of 85, so I was getting good perfusion, and the shock index had lowered to 0.7.
Okay. So what are your considerations? All right, you have to ventilate the patient now. You've got a good ET2. You've confirmed it. You have given a little bit of a whiff, I will say, of push dose pressor.
Right.
You have a positive change in vitals. What are some considerations from a ventilation standpoint?
Well, I had two choices. I could bag the patient, which I had done briefly just to establish breath sounds, chest rise and fall. Or I could move to mechanical ventilation. And I chose to move to mechanical ventilation because I no longer wanted to jeopardize my patient's blood pressure. And positive pressure ventilation affects a patient's blood pressure because it affects the right side of the heart. And I didn't want to take a chance in my patient becoming more hypotensive than what I had already seen, even though she was borderline.
Yeah, and remember, and that's comes back to the blog I wrote and the journal article. Lori and I came up with factors. Right, the number one piece of post-intubation hypotension is positive pressure. We take a patient that is breathing based on negative pressure and we then transition them to positive pressure. We completely defeat the whole aspect of how negative pressure breathing interacts with the right side of the heart and optimizes preload. So you immediately reduce preload by going to positive pressure ventilation. And I think that's where we have to be very, very focused on, even though we've done it that way for years and years and years, is it probably better? And I think it's hard, right? Not every EMS agency has mechanical ventilation. We use Revell ventilators at Allen County EMS. Every ambulance has one. So we can make that decision. Aeromedical side, most places have gone to Hamilton T1s. So again, you intubate in flight, you have the ventilator right there. You intubate in the ambulance on the scene flight, are you taking your ventilator with you? Most of you are probably still bagging your patient back to the aircraft. And what I would say is that's probably not the standard of care. It shouldn't be the standard of care. We really understand that is, and we see that in Dash 1A. We're seeing a lot more post-intubation hypotension than we are peri-intubation hypotension.
But I have to question, is ketamine being blamed for the hypotension when it's actually the positive pressure ventilation with the BVM?
I agree. 100%. So went to mechanical ventilation, as I said, and we use a Revell ventilator. Initial AC 16, tidal volume of 420, PEEPA 5, FiO2 50%, IOD ratio 1 to 2. It's a very standard patient. Hindsight 2020, is the rate high enough? Didn't have an ABG. I don't think at that point we felt like the tachypnea was significant enough to match the rate. I think hindsight 2020 probably would have been safer to bring the rate up to 2022. That was definitely my fault. I initially set up the ventilator, and so, reflecting on that, and it's easy now to armchair cornerback and come back to knowing what happened after. So let's talk about really what do we do after the intubation. We got the ventilator set up. At this point, I have left the scene again. You were transporting.
Well, before you ever got back to your truck, my patient was tearing. So we have the vent set up, and I chose to sedate again, and I chose to do it with 70 milligrams of ketamine. The last thing I want is a sick patient feeling the pain of an intubation. So I continued my post-intubation sedation at 70 milligrams 70 milligrams, 1 milligram per kilogram of sedation. And then we continued transport. We were at the county line. I was still approximately 12 to 15 minutes, depending on traffic, even with emergency traffic, from arriving at the ER.
Okay. And then at this point, you did continuous ketamine every 12 to 15 minutes, and you opted, based on that soft diastolic pressure, to continue to give a push-dose pressor pump.
I did. I gave a total of 40 mics from start to finish of push-dose pressor. And that's where hindsight, learning from Jeff Jarvis, I probably should have hung the norepinephrine and not dealt with the push-dose pressor. I don't know that the patient was impacted negatively or positively either way. I felt like we had good results. Yeah. I definitely delivered her better than what I found her, because she would have died.
Well, and I think it comes back to understanding a MAP of 63 regardless. It stayed pretty consistent throughout, even with the push-dose pressors. Is that really a perfusing pressure for her? I would probably say she's hypertensive normally. We want a MAP of 65 or greater. Mm. We say permissive hypotension, and I know a lot of physicians really struggle with that term in trauma, but this isn't a trauma patient. No. So a MAP of 63 probably isn't doing what it should be doing. We have no Foley in place. We don't know what their urine output is. And so I think, and Jarvis and I and you have talked about that, and I think he's considering maybe making that change at his service where every RSI. Now, there's going to be those outliers where blood pressures are high and stuff like that, where the clinicians are going to have to make a good decision. But, he's talking about basically starting Levophed on every RSI and keeping that on through the 10-minute phase post-intubation, and then titrating that down or removing it, right? Just to work through the -1A algorithm and make sure that we're doing the right things.
And I think your point emphasizes the importance of clinicians not being, for lack of a better term, cookbook medics. Clinically thinking, knowing that the vitals are vital, that you have to interpret what you're seeing with your patient, you have to interpret your vitals and make sound clinical decisions based on what you're seeing, and not just follow, if I see this, do this, because sometimes it's just not applicable. It's not best for the patient.
All right. So at this point, you arrive at the hospital. MAP has increased to 75. BP is now 126/49. Heart rate's 97. So I think that's the other thing that I hear a lot of in the classes is that, if I keep giving these bumps of push-dose pressor, even if you have a tachycardic patient, let's say the patient has a rate of 130, 140, is that really going to change the heart rate? Well, if you look at the heart rates prior compared to the heart rates after the epi, you're only seeing a bump of 5 to 10 points.
Yeah,
so it's pretty small. Yeah, I agree. And so obviously you have a good MAP now. You have a pressure that's much better. Heart rate has not significantly increased. And so let's talk about really the final diagnosis, and then we were able to learn some stuff on through ESO on the
Right.
ABG and things like that.
One of the beautiful things about ESO is that I get to see outcomes. I have follow-up with my patients. And I think historically, that's one of the hardest parts about EMS is that you invest in these patients for, in my case, in a rural service, 30 minutes, 60 minutes, and then you never know. I mean, sometimes you can call the hospital ER and get a nurse that's compassionate and has time to give you some follow-up. But since we have moved to ESO, we do have more follow-up with our patients. So final diagnosis, DKA, end-stage renal failure, acute respiratory failure, pneumonia, sepsis, hypoxemia, and acute encephalitis.
Yeah.
Sick.
A lot.
Yeah, she was sick.
Yeah. Yeah, and then going back to her ABG, she had a pH of 7.03 on arrival, a PaCO2 of 25, PaO2 of 111, and a bicarb of 7, right? Anytime you see a bicarb less than 10, that's always a red flag. She definitely was in a partially compensated metabolic acidosis. Her tachypnea was not as significant as you probably would think with her, a standard Kussmaul compensation where you see in the 30s. But you got to remember, and we really didn't elaborate on that, she'd had a lot of diarrhea. And diarrhea, when you look at diarrhea from that standpoint, remember diarrhea also causes significant metabolic acidosis, right? Vomiting is the one that causes alkalosis, right? Her vomiting was very minimal. It was late in that stage. And remember, guys, anytime you have somebody that is, and it's very easy, and I think bias comes in here, right? She had vomiting, she had nausea, she had those symptoms. It's easy to translate that back to the GI issue.
Right.
But remember, her ultimate diagnosis of DKA, her sugar was high. Ketone production will cause nausea and a bellyache and things like that. And it's so easy for us to miss that.
But I think also we have to recognize that we intervened pretty quickly. In reading her report, the daughter of this patient left for work an hour prior to my arrival. Patient was alert and oriented. She was moving around the house. She stated to the daughter that she was sleepy. She was going to go lay down for a little bit. But she deteriorated pretty quickly. And our interventions, I think, probably stopped the vomiting before we got a real picture of what was going on with this patient.
Yeah. Well, is there anything you want to add to this case? Obviously, we've talked about a lot of stuff on this case. We've talked about really decision-making, airway decision-making, shock index, modified shock index, medication selection. Ultimately had a patient in a partially compensated metabolic acidosis that was kind of hidden. And it definitely snuck up on me a little bit. I definitely saw it in the end title, but I don't think it really slapped me in the face, and it wasn't easily identifiable, just reflecting back. I mean, I saw it, I clued in on it, but her presentation didn't match that. So right. I think it's just important to understand that even though we teach DKA patients, Kussmaul, rates in the 30s, they don't always present that way. And tachypnea in itself should just be a red flag, and I think we need to do better in looking at that a little closer.
If nothing else, this case just emphasizes the importance of critical thinking. Our patients don't read the textbook. It's not going to be textbook. It's very rarely textbook. And so without some critical thinking and evaluation, patients are in trouble. I got lucky. This patient was in trouble. I was surrounded by an excellent partner, an excellent team of providers that came to me twice. And I got very lucky with my management of this patient. But this could have very easily have been one of those patients that we sat and talked about and said, I wish I had done this, or I wish I had seen this, or I wish I had thought about this. And that keeps me humble. That keeps me hungry to learn.
Absolutely.
And not to accept mediocrity.
Yeah. I think it's good. These cases are nightmare serious cases because of just the complexity and how they have these hidden little pathways that go down. And it's really easy. There's a lot of stuff that we talk about, you and I, about bias, and there's some good stuff coming on about that. But there's a lot of different pathways of bias that we could have fallen on in this case.
And you know, I'm going to talk more about bias later, but I think it's very easy to project your bias falling into a predictable category. And you have to really do some serious self-reflection to understand that your true bias is outside of your predictable category. It might shock you where your true bias lies. And I know it did me.
The last thing I want to really talk about, not to put you on the spot, and we haven't really discussed this, but you know, RSI for Allen County is about a year old. We do a really good job with 100% CQI. We've had first pass success. Now, I wouldn't say that we've had first pass success perfectly without maybe a drop in blood pressure after. We've tried to really rectify that with prophylactic push dose pressors and really focusing on shock index and you know, not every patient is going to be perfect, but from your standpoint, talk about how this patient was much more clear to you from a clinical course standpoint. When you start talking about airway decision making, and we always say, you know, the whole adage of intubate if they have a GCS less than 8, right? We don't teach that anymore. We teach, can they control their secretions? Can they follow your commands? And what's their clinical course? And clinical course is a struggle for a lot of people because the perspective is only as good as your understanding of medicine and your experience. And so that is a really difficult piece to a lot of providers. And so to really talk about how this patient was, you know, maybe guided by previous calls where you had to make that decision.
I was very nervous about RSI. Now, I don't back down from a challenge. I want to learn. I want to be the best that I can be. You give me protocol clearance, and I promise you, I will research it. I will go to courses. I will get my hands dirty. I will know all about it, and I will be the best that I can be. But RSI weighed heavy with me. And I still don't take it lightly. I hope I never take it lightly. The hardest thing that I found with RSI is that you do have to evaluate patient clinical course. And in the past with drug-assisted intubation, you know, unless that patient was just circling the drain, we did not establish drug-assisted intubation. You know, I don't know how many times I've been in the back of the truck even before I was a medic, and like, well, they're oxygenating pretty well. I mean, they're at 97. Well, yeah, they are at 97, but can they protect their airway? And what's their clinical course? I had a patient that had OD'd, and she was doing a pretty good job protecting her airway, and she was doing a decent job momentarily with her clinical course until she decompensated to the point where it was a train wreck. And it's one of those things, clinical course is one of those things that once you see it, definitively see it and recognize it, you can't unsee it. And I think that is a huge hurdle for new paramedics, inexperienced paramedics that are taking on a new protocol to clear. And it's important to have good leadership. It's important to have good education. It's important to have excellent training to help guide that recognition. And I'm very thankful that at Allen County we had all of that.
Yeah. Well, I agree. I think once you see it, and we had a previous call where, you know, we talked about it, you saw it, and once you see it, you can't unsee it.
Yeah.
Amazing case. Do you have anything else you want to add?
It's just a privilege to get to do the job that I do every single day.
Well, guys, you know, again, if you have any questions on this case, please email me, eric.bauer@flightbridgeed.com. I will put Kari's contact information in the show notes. Thank you for joining me. We're going to do a lot more of these. If you want her information in any other way, you want to reach her, again, just reach out to me, and I will make sure that you have access to her email and contact information.
It's a pleasure being here today.
Appreciate you guys.
Thank you. Have a good day.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.